Hello and welcome to Unstress. My name is Dr. Ron Ehrlich. Now, before I start, I would like to acknowledge the traditional custodians of the land on which I am recording this podcast, the Gadigal people of the Eora Nation, and pay my respects to their elders past, present and emerging. Well, today I have the pleasure of welcoming back Dr. Thomas Levy, who we spoke to in the last episode just recently about rapid virus recovery. Thomas is a cardiologist and a lawyer, actually. He has written many books and many articles, and the episode we discussed in part one of this was rapid virus recovery. And in this episode, we are going to be talking about the hidden epidemic going on right underneath your nose, people's noses. The silent oral infections causing most heart attacks and breast cancer. It's a big call, but as you will hear, Thomas has very strong and definite views about this, and I share many of those views with him. Having been a holistic, biological dentist for 45 years, who has engaged very seriously with these topics of mercury toxicity and oral infections, this is a subject that is very dear and close to my heart. So it was wonderful to have Thomas, not just a medical practitioner, but a cardiologist, address this and has been addressing it for the last 25 or 30 years so proactively. I hope you enjoy this conversation I had with Dr. Thomas Levy. Welcome back, Thomas.
Glad to be back, sir.
Thomas, we spoke at our last meeting on your wonderful book, The Rapid Virus Recovery. And of course, that took up the whole episode. And I was really looking forward to speaking to you about your other book, The Hidden Epidemic, which is going on right underneath people's noses. And you also shared with me an article that you wrote recently on root canals as being the cause of breast cancer. And that was a very provocative statement. I'm being a dentist, and not just being a dentist, being a holistic dentist, or in America, I think you call them biological dentists. I've been that for 45 years. So this is a subject that I'm very well aware of and have grappled with professionally all that time. So to have you, a cardiologist, write such an amazing book and article is really fantastic. So thank you for that. Tell me how you became so interested in oral health and why does it matter?
Well, Dr. Hal Huggins, who I consider to be the father of biological dentistry, back in 1993, I met him in Colorado Springs. I was a traditional cardiologist at the time. Although I thought I was helping people, I had a feeling inside myself that this wasn't my path. And the old expression goes, when the student is ready, the teacher will appear. I swear within a few weeks to a month of having that feeling really strong, I met Dr. Huggins. And anyway, to make a long story short, I completely gave up my cardiology practice and began doing consultative work with Dr. Huggins at his dental clinic, a massive operation, 60 employees, seeing really sick patients from around the world. And more specifically, I saw the extremely dramatic effect that a 50-gram infusion of vitamin C has on someone, little old lady, neurological conditions, really weak. And she just got stronger and stronger and stronger while getting teeth pulled out and everything else imaginable under the sun as far as traumatic dental work goes. Finally wanting to get a meal somewhere at a good Colorado Springs restaurant with her caregiver before she retired for the evening. And I said, Hal, what's going on? And he pointed out the IV. And when he told me it had the vitamin C in it, 50 grams, that meant absolutely nothing to me at all, except for the fact that I'm not in the habit of denying what my eyes have witnessed. And they witnessed something dramatic. And literally at that instant began my 30-year odyssey now with vitamin C, researching it, writing about it, working with it, and all the ancillary things that comes off of that, which relate to the dental work. I mean, vitamin C is the ultimate antitoxin, and so much of dental entities are the ultimate toxins. So that's where the natural marriage comes together.
Yes, it's just so interesting and great that you're using these orthomolecular approach. It is interesting though, because I think a lot of practitioners don't realize how unique the oral cavity and the oral diseases are, and whether you are taking the pharmaceutical approach or the orthomolecular approach. I mean, I got a referral from somebody, a professor of ear, nose and throat, just a year or so ago, and he was identifying a sinus infection, which in his report he wrote is of odontogenic origin. I don't even think he understood what he was saying because he did agree odontogenic means it's coming from your tooth. And he said, I will treat this. There was an infection at the tip of a root. And he said, it's of odontogenic origin, but I'm going to treat it with 6 weeks of antibiotics and anti-inflammatories. So in the one hand, he said, this is of dental origin, but wearing his professor of ENT hat, couldn't quite accept that he needed some help in dealing with this problem. So he then went on to treat it aggressively with pharmaceuticals. And one could say, okay, that's one way, and treating it aggressively with vitamin C is another way. And I agree that it supports the immune function, which is a big difference. But you still need to deal with the dental infection, don't you?
Well, sure. And of course, in case there's any doubt, the only approach to that is extraction, because once the tooth is infected, the pulp is necrotic and the tooth is dead, and you will never restore that tooth to health. I mean, you might restore it to a pain-free status if you do something ill-advised like a root canal along those lines, but unless the infection is in the gum or periodontal area and has not yet infected the pulp of the tooth, then that's something that can be resolved with a number of different measures. But once the tooth is infected in the pulp, you have bacteria throughout all the dental tubules, and you have, as long as that tooth stays in the mouth, an infected tooth for life. It's very interesting that about the referral from the ENT, because something that I mentioned, I came across in doing my research, that as much as 70% of all chronic sinusitis is due to infected maxillary tooth abutting the sinus. I mean, there are some reasons why sinuses get infected, but for the most part, it's like anything else. And as Dr. Huggins often told me, you can't dry off while you're still in the shower. So here this guy was trying to resolve the infection in the sinus while leaving the infection in the tooth unaddressed, which is at least scientifically mind-boggling, to say the least.
Particularly when you actually in your report write,
yes.
this is of dental origin, but I'm going to treat it aggressively medically. But I think for our listener who may not be aware, I mean, there is inside a tooth a pulp, which is the nerve and blood supply of the tooth. And when decay or trauma affect the nerve of a tooth, the nerve can die. And so you end up with necrotic tissue inside a tooth. And the anatomy of a tooth, as you pointed out, is very complicated. It's certainly a breeding ground for bacteria. And when that infection occurs, we take an X-ray, because often it occurs without any pain at all. In fact, I would observe 90%. This still blows my mind as a dentist for 45 years, where somebody can come in with a tiny cavity and be in a lot of pain, and other people have come into my practice with teeth rotted down to the gum.
That's the name of the book, Hidden Epidemic.
Yes, and it's going on right underneath people's noses. And I often say to people, this will be, if you're a health practitioner or a patient, the oral health issues will be of interest to you, A, if you've got a mouth, which most people do, and B, if you are interested in your health and you've never connected the two. But my question is this: eventually that infection spreads to the tip of the root, and it shows up as a shadow at the tip of the root because bone has been eaten away, and that shadow is full of pus or granulation tissue. Abscess. Now, root canal treatment, and we've talked about this in correspondence because you sent me that article, and I observed, and I should just say that in my practice, we did do some and we removed some as well. So a root canal treatment is the most technically challenging thing a dentist does. That's my observation after 45 years. To do well, let's say whatever we call well, okay, by technical standards of dentistry.
As complete an evacuation of the pulp and abscesses as possible would be the...
Yes, and to spread antiseptic through the tooth and leave it sealed off, and then come back a week or two later, wash that all out with more antiseptics so that it attempts to penetrate the tooth. And then you seal it off to the tip of the root. Now, if you don't get it to the tip of the root, if you haven't identified the main canals, you have not done a root canal well. Anybody can do a root canal, any dentist, rather, can do a root canal, but very few dentists can do it well. And when you've done it well, a year later, you can take an X-ray, and where there was pus and granulation tissue, there is now bone. What has gone on there?
Well, certainly, let me say that there is literature that does assert that in abscess teeth or root canal treated teeth that have been debulked of their abscess, not sterilized. No, they never get sterilized. No. They're never sterile.
You can't sterilize. We're in the mouth, but you can't sterilize.
Well, and also within the tooth. When you debulk it, it does represent less of a toxic load to the body. Okay, and there's data to show that.
Right.
And as you alluded to expertise is important as well, because a high volume endodontist certainly is going to do a better job on 15 or 20 root canals a week than a regular dentist does on one or two a week. All right. It's like any surgical procedure anywhere. That's not to say an incompetent person can become competent, but assuming you are competent, practice makes perfect or practice makes better. The problem is knowing with any degree of comfort or certainty, if you're in the lucky few where the pathogens and the toxins and the infected lymph are not disseminating, because the root canal tooth is directly connected to your venous system, it's directly connected to your lymphatic system. It's actually more effective in a delivery of toxins to your body than if you gave yourself IV toxins, because you get it in both the blood and the lymph. And early on with Dr. Huggins formed an alliance with Dr. Boyd Haley of the University of Kentucky, an incredibly brilliant person, good friend. I love him to death. And he had his initial misgivings about Huggins. Dr. Haley was a very critical person, loving person, but critical. Anyway, they formed an alliance, and Dr. Huggins said, I want you to test the teeth that I send to you for toxins, okay? And he, coordinating with dentists around the country, had over 5,000 consecutive extracted root canal teeth. For whatever reason, these came out. They went to Dr. Haley, and he developed a test that looked at the inhibition of 5 different critical energy-producing enzymes in the human body. And he found potent inhibition of those enzymes, toxicity, in 100% of all those 5,000 plus teeth. And for those who immediately say, oh, well, there had to be a contamination, they also tested some extracted teeth for orthodontic purposes. In other words, normal teeth without any problems, but you're making room to put the braces in, those had 0 toxins. So it was a clear reflection. And of course, this is also, as I'm sure you're aware, Dr. Ehrlich, a validation of Dr. Weston Price's work, because Price took out many root canals in patients with various conditions, heart problems, arthritic problems, CNS problems, not only saw resolution in those problems upon extraction, but even more significantly, perhaps, is the poor rabbits. He would take one of these teeth that, let's say, caused a neurological syndrome and tuck it underneath the skin of a rabbit. Within a few days to a week, the rabbit would develop the same neurological syndrome. And then he would take that same tooth and consecutively put it in 30 rabbits, and all of those rabbits developed the neurologic syndrome. So the potency of these toxins is enormous. And this is one of the things where I think we get a little bit misled when we're just looking at the size of the abscess on the x-ray. Okay. Mm-hmm. It doesn't take much quantity of toxins to do this type of damage. Certainly you don't need a round centimeter circumference or diameter abscess. You can just have the tiniest amount. Matter of fact, let me take a step further. They identified in infected teeth, including root canals, toxins that were 100 to 1,000 fold more toxic than botulinum toxin, which modern medicine, even though people stick it in their faces to let wrinkles relax, poison the muscles to let the wrinkles relax, it's considered the most potent toxin on the planet, botulinum toxin. And these toxins in the mouth, not only with root canals, but other infected teeth, infected gums, in an anaerobic environment would become incredibly, incredibly toxic. So, yes, debulking an abscess is good, but that does not even remotely address the issue of toxicity. It probably mostly addresses the ease with which you disseminate the toxins. In other words, if you have a tooth sitting on top of a nice round plump abscess and you do your chewing, you're going to express that more easily than if there's not a large abscess or just a little lining of toxins. So it's probably less ease of dissemination that makes a superiorly done root canal less toxic than another. But my goodness, there's no getting around the toxicity. And the problem is, main problem is, personally, I believe if root canals were eliminated, the lifetime of the population would go up 3 or 4 years at least, something along those lines. But be that away, that's just an opinion. There right now, and correct me if I'm wrong, since you're in the field, Dr. Ehrlich, there does not exist an informed consent for a root canal. Nobody that does root canals tells the patient there is data that shows you're at an increased chance of heart attack, increased chance of breast cancer, increased chance of a wide variety of disease. Or am I wrong?
No, you are right. And in fact, really what we should be doing is getting an informed consent from a patient every time they walk in the door, because the research linking oral disease to all systemic conditions, and we're going to talk about what that connection is, but the link between oral disease and systemic health is so strong that really we should have a disclaimer when patient walks in the door and goes, as long as you are aware that your oral health has the potential to impact every system in your body and promote heart disease, cancer, et cetera, and you accept responsibility for the home care which goes into what we do, as well as our care, then we will work together in trying to eliminate this. I think two things should happen there. One, I agree with you. The oral diseases, if oral diseases were addressed, I think life expectancy would increase dramatically, not just 4 or 5 years, dramatically. But we should get a disclaimer from every patient.
And there's another point that I would add on the uninformed consent that they receive now versus informed, is the patient completely loses their right of extraction. They aren't given the option of extracting it, in which case it would all be resolved, assuming the extraction is done correctly. Not only would there be no root canal, but there'd be no redo root canal down the road. And there'd be no 1, 2, 3, 4, 5 years of toxin exposure throughout the body, hammering that person's immune system. That would have never occurred had they been given the option at the outset of an extraction. And these days, for many people, implants are a great option. Implants, or depending on a strategic location, you can do without the tooth. There's a number of options, as you know well. But the point is right now, this informed consent is completely uninformed. And, I am a lawyer as well, and I'm not a litigious person in general. But if you're the party directly causing a heart attack or breast cancer in your patient, you should be sued if you don't give that person an informed consent. I mean, come on. There's no other area in the body, medicine, biology, where you assume no liability at all for what happens. And basically, right now, when a dentist, endodontist does a root canal, they have zero liability for anything that happens, even though, as you mentioned in the book, in the articles that I've written, the amount of literature now is not minimal, but it's massive. Ironically enough, most of the nasty articles, so to speak, regarding root canals and infected teeth is in the endodontic literature. It's in the literature of the subspecialists that do these root canals. It's almost like they're trying to say, yeah, we know about it, but it's not that important. Or some sort of subliminal message. I don't know. But, and we can discuss in a moment, the evidence is overwhelming. Oh, and also too, it really bugs me, not that you use the term, but we try to be so, in my opinion, pseudoscientific these days by refusing to acknowledge the obvious. So when something clearly causes something, well, we can't conclude that it causes it just because I did it and that happened, or I took it out and that went away. That's cause and effect. I mean, there are links and associations and correlations and all this stuff, but we're talking about cause and effect. They have an enormous amount of literature. It's not easy to do on all conditions, but they've shown, for example, in gum disease that have the same flora, the same pathogens as root canals and other infected teeth, because that's what eventually infects the tooth. They show that good control, hygiene, bring the infection down in the gums, and cases of asthma either disappear or ameliorate. And when the gums flare up again, they get worse. I mean, if you don't feel comfortable labeling that cause and effect, then I think someone doesn't appreciate what the words cause and effect mean.
Yeah, no, look, I mean, you're preaching to the choir here because, I'm talking
to the
last
world.
Year, I know that. But in 2022, WHO put out a global oral health report. And interestingly, and I shared this with you when you sent me your article, that, we'd all agree that cancer, malignant cancers and heart disease are a big problem. I think about 500 million people globally suffer from each. And mental health, big issue, almost 1 billion people. Oral diseases, 3.5 billion people suffer from oral diseases. And I would say that's an underestimation. I think that's an underestimation.
Well, it's interesting you mentioned the WHO. I call it World Health Obliteration. Okay.
I agree with you.
But it's interesting, too, that
I agree with you.
We get so surprised at this idea of infections. I mean, everywhere in your body except your mouth connected to your alimentary tract, connected to your intestine, connected to your anus, is pathogen-free or should be pathogen-free. Okay, so, but microbiomes, normal bugs, they're not only appropriate, they do good things. So we tend to get a little slipshod with the fact that, there's some bugs there, that's no big deal. Well, there are very clear-cut, well-documented in the literature, pathogenic bugs from the mouth. Porphyromonas is horrible. Fusobacterium is horrible. And we find these growing and concentrated in cancer lesions throughout the gut, throughout the GI tract, throughout the body. It's easiest and most common to see them in gut, gastrointestinal-related cancers, but by no means limited to that. In the breast cancer, the breast cancer lesions consistently grow out 100-fold more microbes than normal breast tissue, and most of them are pathogens. I say that because if you're draining the lymph of a normal mouth, before that lymph gets screened through the lymph nodes and purified, it's going to bring bugs into the breast. So the breasts have a normal microbiome because they're continually draining lymph that does have, in a normal mouth, a normal flora coming in. But the moment you get the infection and you get the pathogen overgrowth, then all of that normal flora becomes pathogens, which are highly pro-oxidative. No cancer develops in the absence of a focus of not minimal, but massively elevated oxidative stress. And the breast is able to quite easily handle the lymph when it's coming from a non-infected mouth and flowing through. But when there's a large amount of pathogens in, and people need to understand the lymph system too, especially with regard to the breast. And I'm addressing the breast now because it's the most significant cancer on the planet for everybody, statistically speaking, even though the men don't get it, less than 1%. So it's important to understand that the lymph gets drained, and you can see the lymphatic pattern directly down the neck, into the breast, and then out into the armpits, and then into the systemic circulation through the thoracic duct. And the purpose of the lymph nodes is to filter and sterilize the lymph before it reaches the systemic circulation, which it does no problem under normal circumstances. So when you have an infected tooth, then it's continually draining infected lymph, high pathogen count, into the breast. And at that point in time, if there's anything that inhibits lymphatic flow, then you're starting to set the seed, so to speak, for the cancer as the lymph flow becomes stagnant. And this is supported by the fact that women with larger breasts have more problems. And women with large breasts that get reduction mammoplasties have a less incidence of cancer because they have, not only do they have less breast tissue that the lymph has to traverse, but gravity. Okay. I mean, at the apex of the breast, you need the lymphatic flow to go in the opposite direction of gravity to get out of the lymphatic circulation into the nose, into the circulation. And the lymphatic circulation has a proactive force and moves forward, but it's very, very limited. It's nothing like the blood pressure inside the arterial circulation, or even the venous circulation for that matter. It's lower. So, and when you get the infected teeth, what else do? Over time, they start to infect these lymphatic channels. They break down what's the very tiny but efficient lymphatic valves that keep the lymphatic flow going in one direction. And when this breaks down, you can literally start to get a sloshing, a to and fro of the lymphatic, and it's no longer just going on outside the breast. I think I make the suggestion in the paper. Obviously, if you have an infected tooth, I'm telling you it needs to come out. But I think good hygiene for women, hygienic practices, good health practices, not hygiene, is on their backs where you're then having lymphatic flow accelerated by gravity to do a systematic breast massage each night before you go to bed. That way you give everything cleaned out, a fresh start for the next day. But there's no question at all that I entitled the paper "Root Canals Cause Breast Cancer Frequently," and they do. But any source of infection will do it. As you already mentioned, there's a lot of infected teeth that have never received a root canal. Furthermore, and this applies to all cancers as well as the breast, are the tonsils. Okay. The little old tonsils. It has been found when you inject dye in one of the teeth, within 20 minutes, you can see the dye on the tonsils. That's how quickly and directly the drainage is. Now, when you have a root canal or other infected tooth or chronically infected gums for not long, maybe a few months, definitely within a year, but within a few months, what is draining those 24/7? Well, not only the breast, but also the tonsils. Okay, the tonsils are a major lymphatic organ. And very short term, and this does not get addressed yet too. Right now, we're trying to just get people, docs, dentists, to realize how bad infected teeth are in root canals. And of course, the major job will be getting rid of that, but the job's not done when those teeth come out. Okay, you got to restore the gums to normal, which is not difficult. We can talk about that. And the tonsils, even though they appear morphologically normal size, no evidence of inflammation, when they've been in line with a root canal, they are 100% infected, and they stay chronically infected forever unless you make an intervention to resolve them. The intervention is usually a direct injection of ozone gas several times, topical application of methylene blue on the tonsils, which gets in and knocks out the infection, ear ozone insufflation, which also stops any pathogens that you have from reseeding. Whenever you're knocking out any source of infection in the mouth, you always have to look at the sources that could reinitiate it. So, but the tonsils is more than a chronic pathogen colonization. And finally, and it's very difficult to know when you've done it right unless you have an elevated CRP that comes way down. Then you've got good, solid evidence that your tonsils have been resolved. Okay.
Now, for our listener, Thomas, CRP is an inflammatory marker that you can see in common blood tests.
C-reactive protein.
C-reactive protein. That's it. Yep.
And it's very sensitive test. Then ultimately tonsillectomy. And all this work came from Dr. Joseph Issels in the 1950s and 1960s, who had a clinic for advanced cancer patients in Germany. I think these were cancer patients that the United States had given up on, and they'd run out of funds, both two things that you know what happened when you're sick. And they came to Dr. Issels. Dr. Issels had a very ingenious program for stimulating the immune system and getting people over their cancers. But he noted, now remember, 1950, 1960, that 98% of the patients had between 2 and 5 infected teeth. And infected teeth to him meant root canals or other infected teeth. Well, as we know now with sophisticated imaging machines, that 98% surely would have been 100%. But even if it's 98%, fine. So what he also found, though, and here's the kicker, after several months of initiating his therapies, the cancer resolving, about 20% of the patients would still get a heart attack. And he labored over this for a moment. And then he remembered in his mind that he knew of a rheumatoid patient who had inflamed tonsils. And when the tonsils came out, the rheumatoid went into remission. That was basically his hunch. So incredibly aggressive, I will grant you, but he started then initiating as a routine tonsillectomies in all of the patients after they got all the infected teeth taken out. The heart attacks disappeared. Furthermore, at pathology, in his words, not mine, he found 100% of the tonsils that were extracted, even though they appeared normal in size, normal in morphology, no evidence of inflammation, 100% of them had severe infection at histology. So this is really important. And it also indicates that the tonsils are one of the primary reasons that cause the chronic pathogen colonization inside the coronary artery. That is the invariable reason for all atheromas and coronary artery disease developing and subsequent heart attacks.
When I look at the statistics of the incidence, now not just the WHO, who I totally agree with you. What was the 04
World
again?
Health Obliteration.
Obliteration, yeah. I totally agree with you there. But interesting statistics nonetheless. And I look at the prevalence of apical periodontitis, which is an abscess at the tip of a root. That is the official word, apical periodontitis. Right. That means you have an abscess at the tip of the root. I mean, I'm looking at a study here, 2021 study. 50% of the adult population worldwide have at least one tooth with apical periodontitis. 61% of individuals in Europe. The whole story and incidence of this is why I think 3.8 billion or 3.5 billion is an underestimation, because then we get into the subject of gum disease. Oh my God, that's like 90% of the adult population have gingivitis. 47%, that's the superficial, the gums you can see in your mouth inflamed. And the deeper structures, half the population have deeper periodontitis.
Let me make a point right here, because I found this to be true,
yes,
and you've just pointed out how absolutely enormously important gum health and gum disease is in initiating all diseases, no exceptions, all diseases, which is why the root canals and infected teeth are bad, because they have the same bugs as the gums. Well, and then you mentioned the number of people that have horrible gums. It's so easy. Number one is, and some dentists push hard back against this, others kind of reluctantly acknowledge it, except for weird anatomy teeth. Forget about flossing. Forget about flossing. You need a water pick. You need a water irrigation device. I guarantee you, if you give somebody a sloppy meal and you have them water pick, you have them floss all they want, and then their water pick, you're going to get a ton more stuff out after they water pick. And vice versa, the water pick will get it all out and the floss won't add anything. Additionally, for many people, all the floss does also too is reinitiate a little gum trauma every time you do it. Not many people can do it without repeatedly traumatizing their gums. And what's the resolution? Our good old buddy, hydrogen peroxide. When you get the water pick tank, and I like to use warm to hot water, the warmer the better. I put in a splash of mouthwash, 100 cc's or so of water, and about 30 to 40 to 50 cc's of 3% hydrogen peroxide. And you just water pick with that every morning, and you will regain perfect gums and maintain perfect gums. I've even had cases of what appeared to be advanced chronic periodontal disease, where normally you have the nice little widow's peak of gum in between the teeth. These had, a little flat line at the bottom. You lost it. Those would, in 2 weeks, 2 to 3 weeks, would regrow that nice little widow's peak of gum. The thing is the thing that holds it down is the infection. And that's the other thing too. Is floss is not going to do anything for gum infection. Okay. It's going to, get out the chunks of food and maybe some plaque or this, that, or the other. So, what I said about weird anatomy is I just have two teeth that are they always grab something, and I use floss for that just to get, because they're real tight and they don't work that well. But everything else, and for most people, so this is like one of the simplest, and because of the statistics you mentioned, most incredibly important things that people could do. I mean, I wish I had stock in water pick as I say this, because everyone should have one and everyone should do this at least once a day. Probably the best time to do it, if you're going to do it once, good to do it twice. If you're going to do it once, do it before you go to bed at night so that you don't have the stuff sitting in there for 8 hours before you get up, whatever it is you cleaned out. But otherwise, it's good to do it twice a day.
I think that's great advice, Thomas, and coming from a cardiologist, just amazing. But anyway, I think it's brilliant. As I think we said just before we came on, and I've observed often that the mouth is really the black hole of healthcare. It's kind of doctors and health practitioners know almost nothing about it. In fact, I think the majority would do an oral health assessment by saying, "Oh, hi, Thomas, have you been to the dentist lately?" And they go, "Yes." "Was anything done?" "No." "Do you have any dental pain?"
Check.
"No." "Oh,
Check.
okay. I've just eliminated the most common disease in humanity in one or two questions. Now let's
get on. With 3 or 4 irrelevant questions.
With 3 or 4 irrelevant questions, because as I observed also, and my partners have too, often 90% of oral diseases have no pain associated with them. So that's important. But even the dentists, who it's so easy for us as a profession to get lost in the minutiae. We talk in microns in terms of successful restorations. It's easy to get lost in forgetting that this mouth is attached to a whole body. But what are your observations about how the medical profession, how health professionals approach this, both dentists and doctors?
Well, I couldn't agree more. It's kind of interesting. When I was in training cardiology, I worked with some cardiovascular surgery residents and faculty. And there was this one cardiovascular surgeon, did a great job, good friend, and didn't mean anything to me at the time, but he actually always examined the mouth before they had surgery. Now, obviously, his eyes are not an X-ray, so he can't see anything like that. But I presume if he saw horrible gum disease, he set the timetable for the for the surgery back a little bit. But anyway, it was kind of impressive that someone did that to that degree. Also, I don't know if I'd mentioned this in the past, but I'm sure you're old enough to remember Charlton Heston and Ben-Hur. Okay, 11 Academy Awards, incredible. And they recruited in the film Charlton Heston to be a gladiator because he was slogging in the straw pits with mud to make bricks. And so they wanted to get good, fit people. And take a look at that movie. If you go back there, he's sitting there slogging. One of the soldiers goes up and he immediately goes to Charlton Heston and pulls his lip down. A 25-cent examination. And that's what they do to horses too. So it's just a common wisdom type thing that's been commonly lost. It shouldn't be lost. I mean, and I've said this before, and I think this is the perfect context to repeat it, is if you have a perfect mouth, you're going to live your normal lifespan without disease. Conversely,
I would agree with that.
If you've got any sort of advanced chronic disease, there's no way on earth you've got a normal, non-infected mouth.
You know, you've identified two clinics, Joseph Issel's, who would have got very difficult cases from all over the world, and you've also mentioned Hal Huggins, who similarly attracted really intractable problems that would end up. So these are the apex of clinics in terms of what they're seeing. But in the everyday practice, I mean, to me, I'm amazed that in an oncology practice, in a heart clinic, that an OPG, a panoramic X-ray of the mouth, isn't just standard practice. Well, I mean, talk to us about what you consider to be a comprehensive assessment of a person's oral health.
Well, I would only, ironically enough, I'd only be in favor of the panoramic X-ray if it was a very poor area that didn't have much money and there wasn't anything else available. Definitely get that rather than nothing. But because of the impact that we've been talking about on all diseases, everybody needs a 3D cone beam examination of their mouth. No exceptions. And of course, that's a computer tomography. I mean, it's really, really Star Wars type stuff. You rotate around it and you see all the angles. It's magnificent. The important things to remember, though, about that are it's very technician dependent. So you really need, if in a dental office, to get well-trained technicians, because it could be not like anything else. Well, not like anything else, not like a blood test. It can be done sloppily or well. The second thing is interpretation, okay? The dentist is not equipped to interpret it, okay? Now, and the dentist should not take offense at that, because proper interpretation requires a specially trained dentist or radiologist, okay, that will routinely take 25 to 30 minutes going through everything and doing their dictation. Of course, the dentist spends 10 seconds. Where do I see the abscess? So there's not a lot of them out there, but there are some interpretation services for this type of test. And I would strongly encourage any of the dentists out there that might be listening, don't even try to take the responsibility, because that's the other thing doing is you're taking responsibility you shouldn't take. There's a lot more information on this test than your teeth. It's doing a large part of the head. And if you look at it for 10 seconds and you miss a tumor, okay, and you never get it properly interpreted, guess who's going to get sued and guess who's going to collect? So don't even try to play super doc by thinking, oh, well, I can just interpret this correctly in a minute. No, you can't do it. And the other thing is you need to, every test that you do is enhanced by giving the interpreter the information of what you're looking for. All right. I do echocardiograms of the heart. All right. And I can do it without anybody telling me anything. It's systematically cover everything. But still, if they say, I heard a systolic murmur, there was a positive blood culture, then I'll look at it a little harder, and then maybe I'll see little vegetations on the heart valve that I wouldn't have noticed before. So you got to feed the interpreter as much pertinent information as possible. So in that regard, in addition to getting a good interpretive service to look at these examinations and interpret them, you want to say, I'm especially interested in any evidence of radiolucencies or abscesses at the root tips. I mean, make it clear that's what you're looking for. I mean, tell me as much as you can about the test, but I want you to tell me with great assurance that you've looked at all 32, 30, 28, or 10 teeth that are present for abscesses at the tips.
Thomas, I could not agree more with you there. The 3D X-rays, which have been around for probably the last 20, 25 years at least, have been an absolute revelation for me as a clinician who had looked previously at two-dimensional X-rays, the standard ones, and looked at things and went, gee, I don't know, maybe there's something there, maybe there's not. We'll keep our eye on that one. Yes, we'll keep our eye on that. And then we get a 3D X-ray. Oh, my God. You mean I would have let that sit there?
Well, that on the cover of the book, Hidden Epidemic, we show the Panorex, we show the suspect tooth. You wouldn't consider anything problem with it and then a big circle around it. You go down to the 3D, and not only do you see a huge abscess, you see the sinus wall completely eroded away.
Absolutely. So I totally agree with you. I mean, if someone and less than 5% would come in with all 32 of their teeth through and in perfect order without any history of decay, but 95% of the population have some history of decay, or 90% of the population. So if you have a health condition like heart disease, cancer, autoimmune, whatever.
Oh, and that's
3D
that's the other
X-ray.
point I'd like to make too is don't wait until you feel ill. All right. Whenever you decide to go to the dentist and you have the opportunity, even if you're a kid, a teenager, a young adult, get your baseline 3D examination so that if 5 years, 10 years, 15 years down the road, you got high blood pressure, you got fibromyalgia, you got headaches, whatever, then you repeat the test and see if a new abscess teeth has not emerged. I might add that the person who I got the studies on for the book Hidden Epidemic had 3 abscessed teeth taken out, okay, and did fine for many years. And then she called me up not a year or so ago and said, well, I developed a couple breast lumps and blah, blah, blah. And I said, repeat the cone beam examination. And sure enough, she had 2 more teeth that had pussed out and had to come out in order to resolve the breast condition, because it's not just breast cancer. It's any breast condition at all. All diseases have increased oxidative stress. It's just that cancers have the absolute highest oxidative stress. So you get any type of condition of the breast draining that infected lymph. It's just that in the worst possible scenario, it evolves to a cancer. But clearly repeating the test was what triggered the proper treatment.
And to your second point about proper interpretation, I mean, we have had, in our practice, the Sydney Holistic Dental Centre, we work with a professor of dentofacial radiography who does the assessments for us. And it's usually a 2-page report, and it's very, very thorough. And to your point about liability, because if you do, there is so much information here that a dentist is just not capable, I don't believe, as a dentist myself.
And if not capable, even if you were capable, you don't have the time. You don't have the time.
You don't have the time.
Not an actively practicing dentist.
Yeah. And if you're going to have an X-ray like that taken, why not get the most information you can from it? So I agree with you about that as well. But that raises the issue also about a thorough assessment of the gums, because this involves now, the gum should be like a tight collar around the tooth, and there's a crevice around each tooth, which should be about 2 to 3 millimeters deep, because that's easy to clean with a toothbrush. But a full periodontal exam measures that crevice depth at 6 points on every tooth. That means 192 measurements in the mouth. That is a thorough periodontal assessment as well. I think that needs to be said as well.
I would say this too. not trying to do away with the subspecialty of periodontology, but for someone like that, I would say get on the regimen. I wouldn't bother with that analysis until I had them on the hydrogen peroxide oral irrigation for a month. Then after a month, come in and let's see what, if any, residual periodontal disease that you have.
Well, I would say I love that idea of the water pick and the hydrogen peroxide, by the way. And I also add to that, I don't know what you think about oil pulling. What do you think about oil pulling? Coconut oil.
I don't have a strong opinion about it one way or another. I really have no experience with it, and I don't see it. I don't see much of anything adding that much to gum health after you've knocked off all the pathogens with the peroxide, because that's the only thing that causes periodontal disease is pathogens. Also, of course, if you have a real problem with calculus and you have some hard, bony stuff that's chronically irritating, inflaming the gum, well, that's another story too. But short of having hard foci of calculus and calcium, it's all a matter of, are there bugs there, or have you knocked out the bugs? If you knocked out the bugs, the gums are going to regenerate. It'll only be the really, really advanced cases of periodontal disease where you have a weak foundation and the teeth are already a little rocking in their socket, where you're not going to, in my opinion, get yourself back to complete gum health. But short of that, it's, like I said, not trying to do away with the subspecialty of periodontology, but whoa, this would put a big dent in their practice.
It would. And I think I think if people are motivated to do the water pick with that and good oral hygiene, combined with, of course, we're talking about nutrient-dense diets and all the things you mentioned in our last episode about rapid virus recovery. I mean, if we weren't recovering from a virus and we're wanting to maintain good health, I think a lot of those factors that you mentioned dialed back a little bit would be good daily routines anyway. Would you not agree with that?
No question about it. I mean, wow, if you knock out, or as reasonably as possible, knock down and mitigate all of the, shall we call them, pathogen growing circumstances that the oral cavity allows, wow, everything else works so much better. Because I come back to Dr. Huggins' simple statement, and it was so beautiful and so elegant. When I was frustrated and asking him about some person who wasn't getting as well as I thought they should, and he looked at me somewhat annoyed and said, "Tom," I said, "Yes, sir," that you can't dry off while you're still in the shower. And immediately, I mean, to this day, I now see all therapy as having two major aspects. And they have to have both. One is repair, and the other is prevention. All disease, as we mentioned, is oxidative stress, oxidized biomolecules. So your good diet, antioxidants come in and repair the oxidized biomolecules, give them electrons, and bring them back to their reduced forms, functioning perfectly well biologically and metabolically, enzymes, sugars, fats, etc., proteins. And then the other side of the coin is you got to stop the new toxins. You got to stop the new toxins from coming in and causing fresh oxidative damage. And of course, that's everything else we're talking about. But conceptually, it's very simple. Conceptually, it's so simple. You repair old damage and you prevent the new damage, and diseases disappear.
Thomas, what a note to finish on, because we have covered, again, we both agree, a big topic here of vital importance to anybody with a mouth who is interested in their health and may not have fully connected the two, and that includes patients and practitioners alike. We'll have links to your book, Hidden Epidemic, which is a wonderful read, and the article too, I might add, which has 200 or 300 references just there alone. The
breast cancer article, yes. That's, even though it's a breast cancer article, it applies to everything. It's just especially dramatic because breast cancer is such a big deal around the world, and so many women and their practitioners are clueless about it. And it just tears me apart when I get the new letters every few days from these cancer patients around the world. They say they don't even know anything about this. They say, "Dr. Levy, how much vitamins should I take?" vitamin C should I take? I'm getting my chemo, but how much vitamin C should I take? And then I send them the articles and I say that you haven't paid attention to the elephant in the room. It's infected teeth and blah, blah, blah. And then I get another return. Okay, thank you, Dr. Levy, but how much vitamin C do I take?
Yeah.
I mean, vitamin C is important. You always need it. But there's a lot of times it can't do the job by itself.
And you see patients have bought into the same philosophy that practitioners have. So we've educated each other in many ways, but for you to be doing this kind of stuff for so long and putting it so eloquently, Thomas, thank you so much for joining us.
My pleasure. Thanks for having me on, sir.
Well, Thomas Levy has written so much on this topic and has been in the thick of things. The clinic that he was referring to, Hal Huggins, certainly was one of the biggest clinics in America where people faced with really difficult health conditions would come, and it was all about removing mercury toxicity, removing infections and building immune function. And I agree with so much of what Thomas had to do. I don't necessarily believe it is that black and white that all root canals must come out. Whenever I'm asked this, I always say it depends. It depends primarily on, the patient themselves. Their immune function is a really important starting point, because somebody who has a terminal illness and somebody who is, in inverted commas, in perfect health has different immune function. So it depends on a patient's immune function. Another big depend is the technical skill of the practitioner, because it is a very complex issue. And I'm going to share some images with you, because if you're looking at this on YouTube, and it's one of the reasons you should be on our YouTube channel, you'll get to see just the complexity of what we're talking about. But it depends on the technical skill of the patient, of the practitioner. And it is, without a doubt, in my opinion, after 45 years of dental practice, the most technically challenging thing to do in dentistry, which is a really technically challenging profession anyway. And doing it well is not easy. And that's why in my own practice, the Sydney Holistic Dental Centre, my partners who worked under 25 times a microscope, and utilised the latest and greatest sterilising procedures. They did it because they did it as well as any specialist. And when they couldn't do it, they would refer it to a specialist who could do that or not. And even given that, there were many times we in the practice decided that root canal was not the appropriate treatment for a patient, or retreating a root canal. So it depends on the technical skill, and that immune function needs to be monitored for a lifetime. So what might have been fine a year ago may not be fine in 20 years' time. And so that's what a comprehensive dental exam is all about. And his description of the importance of cone beam, 3D X-rays, and importantly, interpretation, we believe, by a dentofacial radiologist. So not just any radiologist. We've got reports back from radiologists who have looked at a cone beam and given us a paragraph summary. The reports we typically get back from who is a professor of dentofacial radiography, is typically 1.5 to 2 pages in length. So this is really important. But I just wanted to share with you a couple of images to make it easier for you to understand what we were talking about. This is the WHO. Oral diseases dwarf all other diseases, and I believe that this is a gross underestimation. Even 3.5 billion people globally is an underestimation of oral diseases, because the vast majority have no pain associated with them. The last 25 or 30 years have been a coming of age for dentistry, as it has been linked to so many, in fact, almost every physical and even mental health condition. And when we're talking about periodontal disease, we're talking about 4 stages of periodontal disease. We're talking about gingivitis. Now, gingivitis is that part of the gum that you can see in your mouth, and if that's inflamed, that's gingivitis, easily reversible, easy to treat, and it's very superficial. And there's a little crevice around the tooth, and if you're looking at this image, you will see that crevice is 2 to 3 millimeters. That's a little measuring tool that is used in a proper comprehensive oral exam. And sometimes when the gum, there's a buildup of deposits, the gum gets pushed away from the tooth and a pocket develops. So you just cannot get a brush or floss. Better with a water pick, I agree with Thomas there, but it's very difficult to get to the bottom of these pockets as they go deeper. And the early to mild periodontitis is 4 to 5 millimeters, and moderate periodontitis is probably 5 to 6 millimeters. And advanced periodontitis, you have a 6 to 8 to 10 millimeter pocket down the side of the tooth, which you have no chance of cleaning effectively. So that is the stages of periodontal disease. How common is it? Very common, in fact. In Australia, relatively high in over 15-year-olds, and a third of the population have moderate to severe periodontitis, which I've just shown you is with over 5 millimeters, 5 to 6 millimeter pockets down the side of a tooth. In America, 94% of adults have gingivitis, again, quite superficial and easily reversed, but almost 50% have periodontitis, and over the age of 65 years old, that number goes up to 70%. So when you think of people with chronic degenerative diseases like heart disease, cancer, autoimmune conditions, mental health issues, dementia, let alone young people with infertility problems and autoimmune conditions, oral disease is a significant issue, and gum disease is a very common one. And when you do an assessment of those pockets, you should be measuring 6 points around each tooth, 3 on the outside and 3 on the inside of a tooth. And that means there are 192 measurements in a comprehensive periodontal assessment. And it's important to do those measurements because when you're looking at this image, you can see that, in fact, one tooth might measure at 1.3 millimeters and another part of the same tooth might have 6 to 7 millimeters. And just to underscore that, this is an example of doing, now this is a model, bear in mind, with clear gums, but you can see going along here, there's no pockets, 3 millimeters. And then we go into, here's 5 millimeters, but in the same tooth, there's 7 millimeters. So this is really nuanced. And when we get into the back teeth, it's even more complex than that because there are roots that you've got to get in between. And how do you clean these? This is why professional, comprehensive oral exam is just so important. And in some instances, it may well be better to remove a tooth. This is the panoramic X-ray that Thomas described, and it's a panoramic X-ray of somebody with very few fillings. I can count 4 or so fillings off the top of my, as I look at them, those white things, you can see impacted wisdom teeth. But you look at the next one and you see these are what root canal treatments are all about. And as I look just on this X-ray, I can see infection down on the bottom left and probably up on the top left. But we would need a 3D X-ray, and a 3D X-ray is far more comprehensive. I mean, this is just some of the images that one gets and one needs to look at very, very carefully. And this is why it needs to be done professionally by a radiographer that is used to looking at it. Look, the mouth is a really complex area. There are so many nooks and crannies, not just to mention tonsils and under the tongue, but around 32 teeth, which is very unusual. But also the anatomy of teeth is really complicated. And that all needs to be looked at. And so when we look at the anatomy, it comes in all different directions. And of course, the whole structure of a tooth is open to infection. So the anatomy of a tooth is complicated. How common is tooth decay? Well, 92% of adults between the age of 20 and 64 have had some experience of tooth decay. It's the most common non-communicable disease globally, tooth decay. And the vast majority of tooth decay is pain-free, has no pain associated with it. It's a big problem in Australia. In age groups 15 to 64, 45% of the population have one or more teeth with untreated tooth decay, and that is important. And when we're talking about infections at the tip of a root, apical periodontitis is what that diagnosis is. And the literature, as we outlined, is quite specific, or quite horrific. In fact, 50% of the adult population worldwide have at least one infected root. And, you can pause this and look at some of the others. My question to Thomas was, the image on the left shows an X-ray with a shadow around it. And that means there's no bone around the tooth. And when we look at the tooth 6 to 12 months later, there is infection. So look, we'll have links to Thomas's books and articles. They're brilliant, and I would encourage you to look at them. I hope this finds you well. Until next time, this is Dr. Ron Ehrlich. Be well.
This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.